Without further, our first speaker will be Frank Mahoney. And Frank is an infectious disease epidemiology, and I'm not going to read the entire, you have it. He's working for the Global Immunization Division at CDC, and he's currently seconded at the IFRC, International Federation of Red Cross and Crescent Societies, no? In Geneva. Frank was the team lead for CDC for Ebola response in Nigeria and Liberia. And he has worked before also in Indonesia and in the Middle East region, and a lot in immunization. So plenty of experience on the matter at hand that Frank is going to tell us on Ebola. And he's going to talk about the impact of the West Africa Ebola virus disease outbreak on the epidemiology of other infectious diseases. You have 15 minutes, Frank. Okay. Thank you.
Thank you. Thank you for the kind introduction. And before you start the clock, I just wanted to mention that I was actually at a meeting in New York of global partners on immunization, on urban immunization. And this is a group that's spontaneously formed with all the key global partners on immunization. And so there's a lot going on, I think, and we're trying to address the equity gap in global immunization, recognizing that a lot of the unvaccinated children reside in urban areas. My only wish is that we had these two meetings together. So I'm going to talk, I'm going to talk about the impact of Ebola on the epidemiology of infectious disease, focusing first on the workforce and what happened to the provision of health services, then talk about the changes in the epi of priority diseases. And I wanted to take the opportunity to share some of the lessons learned, my experience with Ebola in urban settings. On July 17th, Patrick Sawyer, he was a diplomat with suspect Ebola, left Monrovia and traveled to Lagos, got admitted to the hospital with a provisional diagnosis of malaria. The chief medical officer suspected Ebola 2 days later in order to test, and that was subsequently confirmed, and he died. This is the chief medical officer, and this was the information we got on our case investigation form. On getting to the patient, I discovered his IV line was by his side and picked it up with bare hands and put it on the drip stand. I called the nurse to assist the patient to the toilet. I had a cut on my hand and did not remember to wash my hands until much later in the shift. When I read that case investigation, I thought, that sounds just like the way I practice medicine. And when I was an intern at Baylor Hospital in Ben Taub in the early 80s, right during the emergence of the HIV epidemic, and we all didn't have concern about exposure to infectious body fluids. And unfortunately, many of the healthcare workers in West Africa practiced the medicine the way that I did. And in total, there were 815 healthcare workers who got infected. Among those 635 whose test outcome was unknown, 66% died. So these infections had a major impact on the health system. Early in the outbreak, a high proportion of the Ebola cases occurred among the health workforce, around 13 to 15%. And with a lot of training on infection control, similar to what we had to do when we implemented the OSHA standard, it literally trained every health worker. They were able to reduce the proportion of healthcare workers down to around 1% at the end of the outbreak. The number of the types of healthcare workers were diverse. They were from all aspects, but mostly they were workers that had primary contact with patients, nurses' aides. And most of the infections, the overwhelming majority of the infections occurred in the community. And I think what was happening is people were afraid to go to the treatment center, so they go to a healthcare worker in their community seeking care. And of course, these workers are being concerned about their community members, so tried to provide it. You can see the geographic spread of those infections. They weren't all in the urban settings. They were a lot in the rural settings as well. This had a major impact on the healthcare system. It led to the closure of many facilities, limited provision of services, concerns among the healthcare workers about becoming infected in the healthcare setting, And at the community level, there was fear in the community about getting infected by going and getting treatment in a healthcare setting. And there was a subsequently decreased utilization of services. There are a number of studies looking at the impact this had. You can see in this study in Sierra Leone, when they looked at the pre-Ebola period compared to the peak Ebola period, there was a reduction in visits for malaria, ARI, pneumonia, acute watery diarrhea, and there were an increase in the number of patients that came in with measles, an 80% increase. There are many other studies, these are just a sample of them, that all showed a decrease during the Ebola outbreak of HIV testing, administration of vaccines, decrease in ARV compliance, decrease in outpatient visits, HIV testing for new enrollment in HIV care, a new diagnosis of TB. There's a nice study conducted at the community level where they looked at caregivers in the community to see about their attitudes about utilization of health services. And this slide shows some data I think it's in Sierra Leone, where they looked at the proportion of people that were ill. They did community-based, population-based survey. And they found in the upper slide, you can see that among households with sick children, around 25% of the households, only around 40% sought care within the healthcare system during the peak of the outbreak. That quickly rebounded up to 80 to 90% by March of 2015. They resampled this population and in June. So during the peak of the epidemic, people stopped accessing care, but it seemed that they quickly recovered. Those changes in utilization led to major changes, where it was concerned this would lead to major changes in the epidemiology of HIV, malaria, and TB. And this is a study, a model looking at what would the impact be on malaria. It was based on an estimate of 50% reduction in treatment coverage among children less than 5 years of age. And these authors estimated there were approximately 7,000 additional deaths due to malaria as a result of the outbreak, and a change of approximately 50% in attributable mortality due to malaria in all 3 countries. This group did a similar analysis for HIV disease, again, based on a 50% reduction in treatment with ART among persons 15 to 49 years of age. And they estimated there were around 1,000 or 1,100 additional deaths, and change in attributable mortality around 15%. And then finally, for TB, they based again on a 50% reduction in treatment for both drug-susceptible and resistant TB. They estimate around 3,000 additional deaths and subsequent changes in attributable mortality to TB. As I mentioned, these aren't the only diseases that were impacted. People stopped coming for their immunizations, and all 3 countries experienced a reduction in EPI coverage for both DTP3 as well as measles. And that's led to an increase in susceptibility. This slide shows the susceptibility by age group and a susceptibility profile based on vaccination coverage. And you can see the 0 to 3-year-old children, there's a large number of susceptible children due to measles. And without, as expected, all the countries experienced measles outbreaks in 2015. They all implemented measles as supplemental immunization campaigns to mitigate those outbreaks. There's been one study I can find looking at all-cause mortality. This was a study in Moyamba District in Sierra Leone. They reviewed burial team data for a 5-month period, November 2014 to April 2015. They reported 496 deaths among children less than 1 year of age and 786 among children less than 5 years of age. And around 1,300 deaths among the persons less than 50 years of age. Ebola only caused 2% of these deaths. So this is reviewing all the burial data. These were that mortality was 3.4 times higher than the mortality than the average preceding 3 years. Again, this is a bit biased because death registration may not be good, but so it's a threefold increase, but it may be due to ascertainment bias because there weren't burial teams prior to the Ebola outbreak. Okay. I'm next going to shift a little bit now and share with you some of the lessons learned in management of outbreaks in both Liberia and Nigeria. Early in the outbreak, there were a doubling of suspect cases every 2 weeks. And there was concern that there was going to be a massive outbreak and a lot of hysteria. And as a result of early in the outbreak in Liberia was managed by a presidential task force. And the task force implemented quarantine in West Point, which was received with very negative feedback from the community. There was conflict with the community, a lot of resistance, and it created a lot of mistrust in the government and the whole epidemic response. There was a lot of concern at the time among providers participating in the response. Maserati County was overwhelmed with cases. There were not enough ETU beds. People were dying in the streets, and there are all these models predicting hundreds of thousands of cases. There was debate about the type of care that should be provided. Should it be in ETUs? Should it be at home? Should there be transit centers? There was concerns about managing patients in the healthcare system, which had already had huge impact due to the beginning of the outbreak. At that time, one of my good friends and colleagues, Peter Graff, we got together and he asked for a meeting. He said, we need to come up with a strategy. He set ground rules. He said, we're going to all come to the meeting. We're all going to agree. If you don't agree with a strategy, then you have to come up with an alternative strategy that we all reach consensus on. And it was a 2-day meeting that had a lot of debate, a lot of consensus building. And we came up with these 4 strategies. First was early identification of suspect patients with intensified surveillance, contact tracing, dedicated treatment centers, and community engagement as part of that strategy. Safe transport of patients, preventing transmission within the healthcare setting, and safe burials. What the strategy did not include was the treatment within the existing healthcare system, distribution of home healthcare kits, wide-scale support for wash and distribution of hygiene kits was being proposed at the time, and then involuntary quarantine of infected households. This was a quite timely meeting because 2 days after this meeting, President Obama went on TV and said the U.S. government was going to distribute 600,000 home healthcare kits in Liberia. And fortunately, we had the debate and made a decision independent of pressure from Washington that this was not going to be our strategy. And we put a stop to the distribution of home health care kits. There were challenges, as you probably all know, in building ETUs. They were expensive. They costed a lot in terms of money and human resources. Training took a long time to find people who could be mentored and put into an ETU. The operations and maintenance was expensive. Community acceptance was not good, and took several weeks for construction. Nigeria had a crisis. This is an email sent to the CDC director. This was 10 days after Patrick had been admitted. There are 8 highly probable cases and 2 that sought care in private hospitals. We're moving patients to the TB isolation ward in Mainland Hospital. Unfortunately, the people in the TB isolation ward were unwilling to leave, and there was nowhere to put these patients. Literally, this was 8 patients, and we had nowhere to put them. We found an abandoned hospital across the way from the TB ward, and we used that with the help of David Brett Major from ETUS to establish an ETU in an abandoned hospital ward, and it worked quite well. We had another abandoned hospital that was set up as an ETU in Liberia. This is Island Clinic. This is a hospital that was renovated by WHO, government managed. It had 100-bed capacity. The manager of the hospital was a kind-hearted soul. She couldn't refuse to admit patients. In the hospital, she admitted over 200 patients in the first week. It was quite chaotic, but it had a major impact. Slide shows the number of ETUs admissions, and shown in purple is Matsarata County. And you can see that with the opening of Island Clinic, shown as IC, there was a remarkable drop in admissions in Matsarata County. After that, the change in the epidemiology in Matsarata County, we still had to deal with rural outbreaks of Ebola in isolated communities. And we had a number of them of people leaving the city, going to rural areas and seeding outbreaks in rural areas. The response to those rural outbreaks was what we call the RITE strategy, rapid isolation and treatment of Ebola in rural settings. And you can see the impact that that had over time, showing these outbreaks. For example, early in the outbreak, the intervals show the start of the outbreak by the bottom of the bar and the end of the outbreak, and you can see that we were able to reduce that interval quite remarkably over the course of the epidemic. So in summary, Ebola had a major impact on the health workforce and service delivery. It led to decrease in access and utilization. Models and limited data suggest that there was an increase in mortality as a result of this. It's been difficult to measure, but there may have been other measures that mitigated the impact, such as the SIAs for measles, as well as the mass drug administration for malaria. Key issues for preparedness moving forward are rapid detection and isolation of patients is important to maintain the capacity to do that. Identification in advance of facilities to manage patient, infection control practices that are embedded into everyday practice, and maintaining skills of clinical staff. And finally, community engagement is critical for effective response. Thank you so much.
Thank you, Frank. We're going to go through all the presentations, and then we're going to open for discussion.